Hello, everybody. Good evening. We will start the session 3 on day 2 of this Arab Thyroid Association conference. We will have 3 speakers. Each speaker time allowed 25 minutes, and later on we will have 15-minute discussions, group discussions. So if you have a question, you can send, so we'll have later on the answer for these questions. The first speaker will be Professor Naif Boussaidi, professor from University of Texas, Anderson Cancer Center, Houston, United States of America. She will be talking about radioiodine therapy as remnant ablations or adjunct or therapy in differentiated thyroid cancer. Dr. Naif, time is yours for 25 minutes.
Good morning, colleagues. I wish I could be there in person to share this talk with you and have discussions, but we'll have to save that for another time. So today, over the next 25 minutes or so, I'm going to talk to you about radioactive iodine, remnant, adjuvant, and redifferentiation treatments. And I want to thank the organizers and the Congress for inviting me to be here today. I'm honored and hope to see you soon. These are my relevant financial disclosures. And always when we start a talk with thyroid cancer, I like to review the estimates of thyroid cancer. This is in the United States, but worldwide, thankfully, the incidence of thyroid cancer is actually stabilized to maybe even decrease. For many years, it was the only cancer that continued to increase. So for today's talk, we're going to focus on differentiated thyroid cancer, which make up the vast majority are papillary thyroid cancer, and second most common is follicular thyroid cancer. But we'll be referring to them as DTC throughout the talk. We will not be discussing medullary anaplastic today. So the standard therapies, as everyone here knows, for differentiated thyroid cancer is surgery, which is the mainstay, radioactive iodine, which is going to be the focus of today's talk. And then sometimes at recurrence, one needs more surgery followed by more radioactive iodine. And then the third prong of this treatment is the way I explain to patients is to give them a little more thyroid hormone than their body needs, or what's called TSH suppression. And each of these three prongs has a big role in the treatment of thyroid cancer. And we're becoming more specific in when and how we use these treatments. So when we talk about surgery, we can talk about a lobectomy or half a thyroid, or we can talk about removing the whole thyroid with or without lymph node being removed. And then second treatment is the radioactive iodine. We can talk about just ablating the remnant or treating in the adjuvant setting, or actually treating disease that's there, right? What we call residual or recurrent disease. And then giving one thyroid hormone or TSH suppression makes up the third prong. So from a surgical standpoint, identifying that surgeon is the key, right? The best chance at getting rid of this disease for life is surgery. And it's basically the only cure that we have. And so we tend to give a lobectomy or partial thyroidectomy to small volume disease, T1 disease, sometimes up to T2 disease, meaning the size of the tumor without lymph nodes involved. And then we consider the whole thyroid to remove for bigger disease and or if it's invading or has lymph nodes. So some of the things, just to emphasize what the latest guidelines from various organizations have emphasized, is that before going in for surgery, to do good imaging of the neck, the entire neck, not just the thyroid. And if it means that at your center that your ultrasound is not as good, it's okay to use a CT scan with contrast. People used to worry that if we give contrast, we have to delay radioactive iodine. Well, we now know that delaying radioactive iodine is not harmful in long-term outcomes of these patients. So do the best image or the best kind of scan that one has at your specific center. And you want to get a good look at the lateral lymph nodes and the central lymph nodes, not just the thyroid. And so the guidelines, at least the American Thyroid Association guidelines, but several guidelines also follow this, that if patients have thyroid cancer that's between 1 and 4 centimeters with no lymph nodes, then one can either do a lobectomy or a total thyroidectomy, and it was left to choice. But for low-risk papillary thyroid cancer and follicular thyroid cancer, doing a lobectomy or half a thyroid may be enough, and as you may not need radioactive iodine, and we'll discuss that. But if someone were to have a recurrence in those rare instances, that doing a salvage completion thyroidectomy is not harmful, right? It doesn't change outcomes. But for patients with thyroid cancer greater than 4 centimeters or had gross extrathyroidal extension or clinically apparent nodes, it's best to do a total thyroidectomy and remove all the primary tumor that one can see. So now the focus of this talk, radioactive iodine, right? And so radioactive iodine is the original targeted therapy, right? Because it takes what the thyroid actually makes, uses the iodine, and it makes it radioactive and targets it. This can be used in the adjuvant setting, which means there's no evidence of tissue or disease, and you're treating with iodine to lower the risk of the thyroid cancer coming back. Or there may be a little bit of thyroid tissue there, and you're trying to ablate the remnant disease. Or there's actual metastatic disease there, and you're trying to treat the metastatic disease. And there have been varying doses in the literature from when we began treating these patients with thyroid cancer, anywhere from 29 to 200 millicuries, and then using dosimetry versus guessing. So the goals of radioactive iodine therapy are to decrease the risk of recurrence and to decrease the risk of death, right? And I'll show you some evidence for that. But many thyroid cancer patients are at low risk for recurrence or death. Now, treating these patients with radioactive iodine makes it easier to follow up because we get rid of the tissue and the thyroglobulin, but ultrasound has gotten really good at having excellent ability to detect disease. So we no longer have the same arguments to use radioactive iodine. This is an old study that was adapted from the late Dr. Mazzaferri's study, where they show that disease-free survival is actually improved with treating patients with adjuvant radioactive iodine. And this is from a cooperative registry that was done in the United States that showed that patients who have stage 3 or 4 differentiated thyroid cancer, when one is treated with radioactive iodine, it's associated with improved overall survival, right? So this was one of the first data to suggest that radioactive iodine can actually save lives, but in the right patient was the key. And radioactive iodine, of course, has its own adverse events, pulmonary fibrosis if patients have metastases. They can get xerostomia or dry mouth, and therefore can get increased risk of caries. There's a rare adverse event known as nasolacrimal duct obstruction, where the patients complain about tearing. So they can make tears, but it doesn't have a duct to go back into, and this can be requires a surgical procedure. And then there's the age-old question about secondary malignancies and bone marrow suppression and gonadal dysfunction, especially in the right patient. So this was a meta-analysis that was done many years ago now that suggested that the odds ratio of hematologic cancers and leukemia may be increased in those who do receive radioactive iodine. Now that needs to be studied more in a molecular approach, but the suggestion was there. Now, if we say, okay, who should actually get radioactive iodine? We can look at the traditional approach that suggests everyone should get radioactive iodine after total thyroidectomy. And the argument was there were very small adverse events and patients in general did great. But what we found was that there are many low-risk patients that don't need radioactive iodine and they were still receiving radioactive iodine, right? So patients with T1 disease, which means their thyroid cancer is smaller than 2 centimeters, they had no lymph nodes, and they were young, less than 45 years old, and they were still receiving radioactive iodine. And what we found was we're not necessarily improving their outcomes. So why are we giving these patients this radioactive iodine? So we've moved to a selective use of radioactive iodine. And in general, the rule is, let's not give radioactive iodine unless the patient is high risk. And we know that this can lower the risk of recurrence or death. So in order to understand who's high risk, we have to understand the TNM classification of thyroid cancer. And so like other cancers, we have tumor, node, and metastases for our staging. Basically, T is the size of the tumor and whether anything's invaded. The nodes are whether the central nodes are involved or the lateral nodes are involved, N1A and N1B. It's simple. And then metastases, are there no metastases, 0, or are there yes metastases, 1, right? So the N and the M part of this is simple, and the tumor is just a little bit more complicated. But what is different in thyroid cancer, different from other cancers, is in addition to using the TNM status, we have 2 different staging systems based on age, okay? And the age has changed to 55 years. So patients under the age of 55 can only be stage 1 if they don't have distant metastases, or stage 2 if yes, they have distant metastases. Doesn't matter what the T or the N is, okay? And that's because young patients in general are at lower risk for death from the cancer. Whereas the patients 55 and older have the more traditional stage 1, 2, 3, and 4, based on the size of the tumor, what it's invaded, what it's encasing, and whether it had distant metastases or other organs. So when we look at who do we treat with radioactive iodine, there's the American Thyroid Association guidelines having nice graphic that I like to keep in my clinic, and hopefully many of you do in thinking and treating these patients, is let's divide these patients into low, intermediate, and high risk of recurrence, okay? So slightly different from staging, where staging predicts risk of death. This risk stratification was risk of recurrence, okay? And they're slightly different. So patients on the bottom will be those who have characteristics of their tumor that put them at low risk of recurrence, and then intermediate risk there in the middle, and then the high risk there at the top, right? So the high risk have extrathyroidal extension, multiple lymph nodes, large lymph nodes, gross evidence of disease. And somewhere in between is where if one has the BRAF mutation, it's added in. But it's nice in this chart that they actually give you a % risk of recurrence, right? So you can look and talk to patients, especially patients who love numbers and understanding risks, and explain to them what their treatment in the adjuvant setting can actually lower the risk to. So in general, those patients that fall in the low risk category, radioactive iodine is not routinely recommended, and those in the high risk category, it's recommended to treat with radioactive iodine, and then everyone else is in the middle, right? And I know that's a big bulk of patients and it makes it hard, but as one treats more and more of these patients, and it's a discussion with the patient, right? As to pros and cons and what the individual patient's comorbidities are. So as an example, a patient with a T1A, a small tumor less than 2 centimeters with no nodes would not get radioactive iodine because we can't lower their risk of recurrence. They're already at low risk for recurrence. And those patients who have distant metastases or a large tumor that's T4 with gross extrathyroidal extension, we know that we can lower the risk of recurrence, and we may actually, it may be associated with improved survival. Okay. And then all those in between are those intermediate risks, and you can consider various factors and most important, the patient's wishes as well as the comorbidities. Okay, so how do we prepare patients for radioactive iodine? Well, we need the TSH greater than 25 to make those cells hungry for the iodine. We do low iodine diet for 1 week. In the literature, you can find 1 week, 2 weeks. But lately, the evidence is suggesting that one does not need to torture patients more than that 1 week, because low iodine diet is hard. Iodine's in almost everything that we eat, right? So we give patients a handout on what a low iodine diet actually means, including it means don't eat goat cheese, right? We can withdraw the patients from their thyroid hormone to make their TSH greater than 25, either give them some T3 or liothyronine, Cytomel for 2 weeks, and then 2 weeks of nothing, or post-op go straight with 3 to 4 weeks of no thyroid hormone. One does not need more than that. Or one can use recombinant human TSH or Thyrogen if it's available. This is 2 shots, 0.9 milligrams each, that come in a package on 2 consecutive days, and that will raise the TSH high enough to make it hungry for iodine. This is the upper half of a whole body scan that shows thyroid bed uptake, and typically the scan will show anterior, which is thyroid bed, and posterior pictures here. So when it's fainter on the posterior than the anterior, you know that the lesion that we're seeing is anterior. If it's darker on the posterior, then that potentially could be spine, right, instead of thyroid bed. So there have been different studies, and I'm only going to show you the randomized trials as well as the systematic analysis that was done. How much radioactive iodine should we give? 30, 50, 100? And one can see that in all on the left in the observational data that all 16 studied favored, it was sort of in between whether it favors higher or lower dose. And then in the prospective studies, they were also there in the middle. So it didn't fully answer the question. And the question was, does it even favor higher dose, right? When you look at these studies. So randomized trials of high, low, and estimable that everyone here is familiar with were done that took differentiated thyroid cancer patients after a thyroidectomy and randomized them either to withdrawal or Thyrogen and remain on thyroid hormone, and then further randomize them to 30 versus 100 millicuries. And basically, the 2 studies were fairly comparable, but there weren't any Hürthle cell patients in estimable. The number of patients was different, as one can see, and there were somewhat higher risk patients in the high-low study. The definition of ablation success was slightly different, and the follow-up timing was fairly similar. But basically, the conclusion was that there was equivalence criteria on all 4 cohorts, right? You could get good ablation, whether you use thyrogen withdrawal or 30 or 100 millicuries, and disease-free and recurrence rates were not determined, but there really was equivalence criteria in what they were asking, which is ablating the disease and getting rid of the thyroglobulin. So this data was saying, okay, it's still your choice, right? So what about TSH suppression? Well, we know that thyroid hormone is a form of cancer therapy, and it's important to explain this to patients so that they too can understand that this, when they say, oh, you're not going to do anything about my thyroid cancer, well, taking your thyroid hormone every day is a form of therapy. And based on their original presentation, as well as their current presentation, each time they see you, we base the TSH suppression. So less than 0.5 is considered suppression. And stage 1, low-risk patients can keep their TSH between 0.5 and 2, intermediate to high-risk 0.1 to 0.5, and then metastatic disease less than 0.1, but not undetectable, as this can increase the risk of cardiac and bone effects. And so we actually reassess this each time we see them, as opposed to just based on the presentation. Now, when we give thyroid hormone, we tend to, if we're just trying to do replacement, we do 1.6 micrograms per kilo as a guess from the beginning, or 2.1 micrograms per kilo for suppression from the beginning. Now, this was some data from the National Cancer Registry showing that patients who did have a suppressed TSH in stage 3-4 disease it was associated with an overall improved survival, right? So explaining to patients, especially the high-risk patients, that suppressing your TSH is important, take your thyroid hormone, and we got to maintain your TSH between this and this, right? So educating the patient upfront is very helpful. Now, that was remnant and adjuvant therapy. And I wanted to shift gears in the remaining minutes to thyroid cancer that's refractory to radioactive iodine and talk about, is there a role for radioactive iodine or not, right? And so to understand that, we have to understand what is our universe here. So if we took all patients with differentiated thyroid cancer, and if about a third of them recurred, and 10% of them will be metastatic, and 5% of them will be refractory to radioactive iodine. So the rest of this talk is talking about a minority of patients. It's not something common that we're advocating now, although there's many studies looking at this for the future. We're talking about a small piece of the pie. So who is defined as radioactive iodine? Well, there's actually 3/4 definitions that I'm going to share with you today. So if a patient has known sites of metastatic disease with no iodine uptake, or if they have disease progression within 6 to 12 months after treating the patient with radioactive iodine, or have received a total cumulative dose of 600 millicuries or greater. The 4th definition has the least evidence, but it is that if there's FDG avidity and positivity on a PET scan, that iodine is less likely to work and can be considered refractory to radioactive iodine. So if we have patients who have thyroid cancer that's refractory to radioactive iodine, can we enhance or sensitize those tumor cells to radioactive iodine so that therefore we can use radioactive iodine to treat? There have been several people that have been looking at this over the years, lots of research. I'm only going to show you the latest research, which is probably the most exciting in terms of moving the field forward. So to understand how do we sensitize the tumors to radioactive iodine, we have to understand why they're refractory to radioactive iodine. So if we look at the cellular pathways that go wrong, most of them are in the MAP kinase pathway within the cell, and the mutations in BRAF and RAS and other mutations, RET, fusions, and NTRK can render them radioactive iodine refractory and make that sodium iodide symporter not work, okay? So the mutations that they develop to become the cancer, the oncogenic drivers, are the very drivers that we need to work on to resensitize the tumors to radioactive iodine. So this was one of the first papers now about 10 years ago that Memorial Sloan Kettering did, looking at a MEK inhibitor named selumetinib that is not FDA approved in thyroid cancer. Treating the patients for 4 weeks with selumetinib can increase the tumors with radioactive iodine in 12 out of 20 patients, in 4 out of 9 that had BRAF mutations, and all 5 that had NRAS mutations. But 8 of those 12 patients actually reached the threshold of dosimetry to treat them with radioactive iodine, and 5 of those patients got what's called a partial response or had shrinkage in their tumor, right? So it was great to show that, hey, we can treat somebody with the short-term targeted therapy and sensitize the tumors to radioactive iodine, and then treat them with radioactive iodine and stop the targeted therapy, right? Come off that chemo. And then in Mass General, they did a study looking at a BRAF inhibitor named dabrafenib and enhanced radioactive iodine uptake in BRAF mutated papillary thyroid cancer, treated the patients for 4 weeks, and then treated the patients with 4 weeks with dabrafenib, and then treated them with radioactive iodine if they met the threshold, and then looked for shrinkage, restaged them, and stopped the dabrafenib, right? So we've been doing this for a few years at our institution at MD Anderson, and I'd like to share with you some of the data that's been presented in abstract and paper form. And so what we did here was we took patients who were on targeted therapy for various reasons, mainly BRAF and MEK inhibitors in this case, and then treated them with radioactive iodine if their scan became positive, or if the patient chose to, if their scan even was not positive, and looked at the whole body, post-treatment whole body scan. And then we stopped the targeted therapy and followed them up after the radioactive iodine. These are examples of whole body scans because pictures are very helpful. So on the left is the diagnostic whole body scan before targeted therapy. And then on the right is the post-treatment scan after the patient was treated with the targeted therapy and then treated with radioactive iodine. So you can see lungs uptook now and the femur. And here's another patient with a negative whole body diagnostic scan after being sensitized to radioactive iodine using the targeted therapy. They had uptake in the lungs again. So what we said was, how do we know that if we see shrinkage later, that shrinkage in the tumors are due to the targeted therapy or due to the radioactive iodine? So in orange here is the response, the shrinkage after radioactive iodine therapy, and in blue is the tumor shrinkage or tumor changes that we've seen before radioactive iodine after targeted therapy. And what one can see is it does look like radioactive iodine did cause shrinkage in the tumor after exposure to the targeted therapy, in addition to whatever the targeted therapy was doing. So in putting many of our patients together, in summary, the radioactive iodine therapy after tumor redifferentiation or resensitization with targeted therapy does offer durable response. And in our studies, 40% of patients can get a partial response or stable disease with disease shrinkage, right? That are radiographically and biochemically meaningful in a subset of radioactive iodine refractory thyroid cancer patients. And this response is in addition to any prior response that was obtained on the target therapy alone, and it's durable. So what happens is we can stop this targeted therapy after we treat them with radioactive iodine, right? So we managed to keep patients off for a median of about 1.5 to almost 2 years. So there was a median of 20 months in this case. And it would be a sustained, and there is a question that when these patients are on their targeted therapy, if their thyroid globulin rises, that may be suggesting redifferentiation or resensitization. And there's a question as to if we see a sustained increase in thyroid globulin while on targeted therapy, that may be indicative that these are patients who are going to benefit from redifferentiation. Now, this was a case report that we did in a pediatric patient, treated the patient with larotrectinib, which is an NTRK inhibitor. This patient had an NTRK fusion on their tumor. And then we treated them with larotrectinib, and we managed to then treat them with radioactive iodine and get them off their larotrectinib, okay, which was very nice. And we use this in the initial setting. So targeted therapies that have been used for redifferentiation include BRAF inhibitors, MEK inhibitors, the combination of the two, or if they have an NTRK fusion, NTRK inhibitors, or if they have a RET fusion, RET inhibitors, right? So this has gotten a lot more exciting that we have targeted therapies that we can use for short-term, redifferentiate, and then treat with iodine and keep them off for maybe 1 to 2 years. And how, excuse me, this is not universal. We need more prospective studies to prove this. So it's not in the guidelines. But the protocol that we use for redifferentiation at MD Anderson includes treating the patient with targeted therapy. Typically, they're BRAF or MEK inhibitors or combination for at least 4 weeks. We sometimes will do for 2 months, but there's no maximum. If you have a patient who's been on it for a year, you can try the redifferentiation, right? And then we treat them with recombinant human TSH, the 2 injections, do a diagnostic scan, treat them with radioactive iodine, and we either will just use a best guess or dose or dosimetry. It depends on the patient and their comorbidities. And then after the radioactive iodine treatment, we'll stop the targeted therapy after 72 hours. Okay, again, we don't have a trial to prove that. This is what we do. And then Off-targeted therapy will restage them 2 to 3 months later. If they're stable or shrinking, we continue to keep them off the targeted therapy, right? And we managed to go 20 months like that on median in our protocols. But this leaves more questions than answers, right? Who is the right patient to redifferentiate? Is it patients with specific mutations like RAS and BRAF? Is it patients who have small volume disease, which tends to, do better with radioactive iodine in general, or larger volume? Do they need to have progression or just have disease, right? And when's the right time? And what drugs do we use? Do we base it on the mutation? And how much radioactive iodine do we give them? Does the rise in thyroglobulin actually predict who's going to need radioactive iodine? So we basically need more prospective studies with really good controls to answer these questions. So with that, I'd like to end my talk and acknowledge that I'm here talking, but it takes a whole village to treat these patients. And I am an oncologic endocrinologist, but I need surgeons, medical oncologists, radiation oncologists, radiologists, nuclear medicine physicians, and trialists, and all sorts of people. It takes an entire team, including the entire healthcare team. So thank you so much. Please don't hesitate to contact me, and I look forward to meeting you in person.
Thank you, Professor Naifa, for this, as usual, elegant talk. This was registered, and the third talk will be live by Professor Naifa. So the next talk will be by Dr. Tanya Janier, consultant endocrinologist at Hamad Medical Corporation, Doha, Qatar. She will be talking about risk stratification of thyroid nodules, American Thyroid Association versus TRADS. Please, if you have any question, you can send. So we will have later on a panel discussion, Professor Naifa. Dr. Tanya, time is yours.
First of all, I'd like to thank the organizing and scientific committee of the Arab Thyroid Association for inviting me to this esteemed conference. We hope to see you in person next year, but for now, this will be virtual, and we will reconvene for the Q&A at the end of the session. So I was tasked today with discussing the ultrasonographic risk stratification of thyroid nodules based on the American Thyroid Association stratification system and or the American College of Radiology TIRADS system. I have no disclosures. So today we'll appreciate the scope of the thyroid nodules. We'll review the ATA classification system as well as the ACR TIRADS classification system of thyroid nodules, and we'll highlight the differences between the two systems towards the end of the talk. So first of all, a thyroid nodule is defined as a distinct lesion different from its surrounding parenchyma on ultrasound imaging. And the key here is on ultrasound imaging. This is in contrast to the old definition of a palpable lump in the thyroid gland, which was just a physical exam finding. So what's the scope of thyroid nodules? Why do we really care about this topic? First of all, obviously, we want to exclude thyroid cancer, which is present in up to 15% of all thyroid nodules. This is an increase in the previously reported, 4%, 4 to 5% risk in all thyroid nodules. And this is increasing partially because of the increased detection of small low-risk disease. So we're all familiar with this data. This is from the SEER database, and it had shown, quite a consistent increase in the incidence of thyroid cancer over the past couple of decades. But thankfully, we've seen it. We've seen this increase now plateau, even maybe decrease a little bit. Thankfully, as well, the mortality of thyroid cancer has remained stable despite this increase. Qatar is no different, and we've also seen, the thyroid cancer is the second most common cancer in Qatar, and we've also seen a similar exponential increase in newly detected thyroid cancer cases over the past decade or so. So, given the prevalence of thyroid nodules and thyroid cancer in multiple areas around the world, we need to kind of balance the resources we put into thyroid nodules with clinically meaningful thyroid cancers. So, again, we're talking about a highly prevalent disease. The average cost of the thyroid nodule is around $1,700. And, this encompasses anything from the blood test to the ultrasound to a possible FNA to a possible surgery as well. And so this becomes a costly problem. And so we need to balance, unnecessary unnecessary surgeries for, indeterminate cytologies or for, newly detected thyroid nodules, with the cost of these surgeries and the cost of the workup of thyroid nodules, with the patient psychology. Again, in this part of the world, we still have a lot of stigma on the word tumors and cancers, and so labeling a patient with that diagnosis can carry a lot of psychological burden. And we need to manage our resources to be able to care for thyroid cancer that is clinically meaningful. That is, thyroid cancer that, if detected early, can make a difference in the patient's mortality and morbidity. So having said that, which nodules should we care about? First of all, we do have a size cutoff for nodules that, that we continue to follow and assess, and that's a 1 centimeter cutoff, unless there's suspicious lymphadenopathy. Patients with high-risk features, that's patients extremes of age, patients with history of neck radiation, that remains, the most known risk factor to develop thyroid cancer, which is a history of radiation. The rate of growth of the nodules, so a nodule that is fast growing, makes us more suspicious than one that has been present and stable for a very long time. Presence of hoarseness or unilateral vocal cord paralysis can indicate extrathyroidal extension. A fixed nodule on exam with lymphadenopathy and focal uptake on PET scan that's done for other types of cancer or other indications. So we found a clinically meaningful nodule. So we found a nodule in a patient with high-risk features or a nodule with high-risk characteristics. Now what? We should obtain a TSH. And if the TSH is suppressed, we should go ahead with a thyroid uptake scan, a functional scan, to assess whether this nodule is hot or cold. Typically, hot nodules do not warrant biopsies. If the TSH is normal or elevated, then uptake scan is not needed, and we continue with an FNA biopsy if indicated based on the rest of the talk. I do want to mention as well that, previously in the literature, the incidence of thyroid cancer and hot nodules may have been underreported. We are seeing an increase of thyroid cancer in these nodules. So our group would still biopsy hot nodules if the ultrasound characteristics, warrant it. So again, a thyroid ultrasound is needed in all cases of suspected thyroid nodules. Even if other imaging modalities are present, we often receive referrals from our oncology colleagues or our cardiology colleagues or medicine colleagues with incidental finding of thyroid nodules on an MRI or a CT of the neck or the chest, or MRI of the spine done for other reasons. So we would still want an ultrasound, even though we have confirmation of thyroid nodules on other imaging modalities. The ultrasound remains the preferred imaging modality. It provides more anatomic detail, especially of those posterior nodules, and it helps select nodules that are indicated for FNA biopsy. And so these are the features that we look for in the ultrasound and when we assess thyroid nodules, and we are going to go into those in more detail in the rest of this talk. But basically, the echogenicity, the composition of the nodule, the presence of microcalcifications, the margins, the shape, and any associated lymphadenopathy. So in a picture format, this is what low-risk ultrasound features look like and what high-risk ultrasound features look like. So in terms of the composition, a purely cystic nodule carries low-risk ultrasound features compared to a solid nodule. A hyperechoic or isoechoic, that is the echogenicity of the nodule compared to the parenchyma. So a hyperechoic is brighter than the surrounding parenchyma. An isoechoic nodule has a similar echogenicity, and a hypoechoic nodule is darker than its surrounding parenchyma. A hypoechoic nodule carries a higher suspicion in terms of its ultrasound features. The margins, obviously regular margins are low risk compared to irregular margins. Calcifications, this is what we call an eggshell calcification. You can imagine that, what a complete eggshell looks like. It's just a totally calcified nodule, and that carries low risk compared to microcalcifications or interrupted axial calcifications, as we will see later on. The shape of the nodule, so taller than wide in transverse view, again, the nodule growing against the plane of the thyroid, that carries a higher ultrasonographic risk pattern. And the vascularity, with the caveat that vascularity hasn't really made it into any of these stratification systems, just because it's a little bit unreliable, and we'll discuss that a little bit later as well. So again, to drive the point home, if there's anything I want you to take away from this lecture, is being able to identify on ultrasound imaging and not just the report what suspicious nodules look like. So again, the echogenicity, so we're talking about hypoechoic nodules, nodules that are darker than their surrounding parenchyma compared to hyperechoic or isoechoic. So iso are similar echogenicity, and hyper are brighter than the surrounding parenchyma. Again, we're talking about microcalcification. So these are little hypergenic foci within a solid nodule. And, because of these calcifications, we often see this posterior shadowing. So the sound waves of the ultrasound probe cannot go through these calcifications. And so they cause this, black shadow, posterior shadow behind these calcifications. Again, contrast that with a cystic nodule with what we call the comet tail artifacts. These are colloid crystals. So this is just dense colloid material within a cystic nodule, and with actually enhancement posteriorly and not shadowing. So again, we're talking about calcifications within a solid nodule compared to comet tail artifacts within a more cystic nodule, which are benign. Interrupted axial calcifications. Again, if you remember this picture with a complete axial calcification, once this calcification becomes interrupted, this carries a higher malignant potential, because potentially the cancer within the nodule is breaking through this axial. Again, irregular borders, whether posteriorly or whether diffusely throughout the whole nodule, or whether there's suspicion of extrathyroidal extension and involvement of the strap muscles anteriorly, these all carry high-risk features. As we mentioned as well, a nodule growing against the plane of the thyroid. So again, the thyroid, kind of sits at the base of our neck in a butterfly manner. And so when the nodule is growing against that plane, that again carries a higher risk potential. And suspicious ultrasound, suspicious lymph nodes on ultrasound. So regardless of the appearance of the nodule, we sometimes have micro papillary cancers with lymph node metastasis. So regardless of what the nodule might look like, a suspicious lymph node warrants further workup. And so again, you can contrast a normal lymph node with a clear fatty hilum. So this is, where the blood vessels usually feed into the lymph node. You can see in a suspicious lymph node that this fatty hilum is distorted, the nodule is enlarged, and more heterogeneous than what a normal benign lymph node would look like. In terms of the vascularity or the color Doppler flow patterns of the ultrasound, so they can be described as intranodular. So, the whole nodule is vascular, peripheral vascularity, or no vascularity. It is thought that maybe intranodular vascularity may increase a suspicion of malignancy. However, the color Doppler flow pattern cannot reliably distinguish benign from malignant, and therefore it's not included in any of these stratification systems in terms of the assessment of malignancy risk. So what, the thyroid imaging and data system, the American College of Radiology or the American Thyroid Association scoring system does is it takes all these features that we just discussed and puts them into categories. The thyroid system uses a point system where it assigns different weights to different characteristics, and based on that would then the summation of the points would then put the nodule in a different category. The ATA scoring system relies more on the pattern of the sonographic pattern of the nodule and assigns it more on a spectrum of benign to high risk malignant potential based on those characteristics, based on the same characteristics that we just discussed. And that's why it's important to be able to, look at the nodule yourself, regardless of what system you use to score it. But, being able to identify those features that would, more reliably tell you whether a nodule is low risk or high risk, regardless of what system you use to score it. So just a little bit more detail about, both systems. So this is the ATA. We probably all know this figure very well from the 2015 ATA thyroid cancer guidelines. So what the ATA does is, again, it puts these characteristics on a spectrum in terms of the risk of malignancy from benign to high suspicion malignant potential. I think we probably all have this in our desktop somewhere or printed in our clinics and offices to refer to. So, a purely cystic nodule is considered benign. A spongiform, what we call spongiform nodules. So these are those solid cystic nodules that look like a sponge, whether the entirety of the nodule or partially cystic nodules. Once we hit the solid nodule or the solid part of a solid cystic nodule in an eccentric manner, we hit the low suspicion category. And then once we have a hypoechoic solid nodule, this is considered intermediate suspicion, and anything on top of that, so any of those features that we discussed on top of a hypoechoic pattern, so be it the calcifications, the irregular margins, the taller than wide nodule, irregular margins, and possible extrathyroidal and extension, interrupted axial calcifications, or presence of suspicious cervical lymph nodes, that puts it in the high suspicion category. And then again, based on these categories, there's an estimated risk of malignancy, which is placed for each of these categories, ranging from less than 1% for those benign cystic nodules to more than 90% for those high suspicion nodules. And based on that risk of malignancy, a size cutoff for FNA biopsy is recommended. So those benign cystic nodules, no biopsy is recommended. For those very low suspicion nodules, so we're talking again about those spongiform nodules, you could consider, there is no recommendation for an absolute biopsy, but you can consider FNA if the nodule is more than 2 centimeters. Those low suspicion nodules are typically recommended for biopsy if they're more than or equal to 1.5 centimeters, and the intermediate and the high suspicion nodules, there's a 1 centimeter cutoff for FNA biopsy. I'll come back to this. Okay. So the American College of Radiology, the TIRADS system, again, takes those same characteristics. So we're talking about the composition, whether it's cystic or solid, the echogenicity, whether it's hyperechoic, hypoechoic, or isoechoic, the shape of the nodule, the margins, and the presence of echogenic foci, whether they're comet tail artifacts, microcalcifications, or peripheral calcifications, and assigns different points to those characteristics. The higher the point, the more suspicious that characteristic is. And the summation of those points for each nodule places it in one of 5 categories, from TIRADS 1 to TIRADS 5. TIRADS 1 and 2 are considered those cystic spongiform nodules, and no FNA is recommended per the ACR TIRADS system. The TIRADS 3 are kind of equivalent to those low suspicion nodules and ATA, and the recommendation for biopsy is if they are more than or equal to 2.5 centimeters. The moderately suspicious nodules, those are again equivalent to the intermediate suspicious nodules per ATA, and they are recommended for biopsy if or equal or more than 1.5 centimeters, and the highly suspicious if or equal to more than 1 centimeters. So if we put the ATA and the TIRADS kind of, head to head, we can see that at the extremes of malignancy risk, so at those very low suspicion and benign nodules and the high suspicion, so the very low suspicion and the very high suspicion nodules, that, they're in agreement. And that is, those very low suspicion nodules, they don't require a biopsy, with the caveat that ATA, kind of is a little bit more conservative and allows for biopsy of a spongiform nodule if it is more than or equal to 2 centimeters. And at the high suspicion extreme, that FNA biopsy is recommended if the nodule is equal to or more than 1 centimeter. However, those categories in the middle, so the low suspicion and the intermediate suspicion categories, so we're talking about a risk of malignancy of around 5 to 20% per nodule. The ATA is a little bit more conservative, recommending biopsies at lower size cutoffs. So again, if for the low suspicion nodule, The ATA recommends a biopsy if it's more than 1.5 centimeters versus 2.5 centimeters for TIRADS. And in the intermediate suspicion, ATA recommends biopsy if it's more than 1 centimeter versus more than 1.5 centimeter in TIRADS. So, which is better, or what should we follow? Is it ATA or TIRADS? Both have high sensitivity and high negative predictive value. Again, overall, there's a consensus in the nodules at the very low or the very high risk of malignancy. The lower size cutoff for FNA biopsy by the American Thyroid Association in nodules with low and intermediate risk of malignancy offers perhaps a little bit of a higher sensitivity for ATA. So there's less missed malignancies because we're biopsying them at lower size cutoffs, but this may mean more unnecessary surgeries. Again, we're still talking about up to 20% risk of malignancy in these nodules, which means up to 80% benign nodules. The higher specificity for RCR TIRADS is offered through that higher size cutoff. And the argument is that the rate of malignancies that may be missed because of that higher size cutoff for ACR TIRADS is acceptable and probably does not affect mortality and morbidity in terms of earlier diagnosis of the thyroid cancer. So whichever system your practice or your institution follows, it's just important to be effective and efficient, to follow detection strategies and to understand why we are not biopsying, every single nodule that might be detected on ultrasound, and incorporating decision-making along with the patient's characteristics, with the other comorbidities, and with the patient preferences as well. So, given that none of the systems offers us 100% kind of detection rate for thyroid cancers, although we're pretty close in both systems, I wonder whether artificial intelligence may play a role in the future. So there has been a significant development of artificial intelligence in medicine, specifically in terms of imaging, ultrasonography, and nuclear medicine as well. And it's very interesting, it's very futuristic, but I guess we're there. So it's not as futuristic as it may have sounded before, but, basically the idea is to teach the computer program how to draw conclusions and how to make connections between the images that are being fed to the computer and the results. And this is what they're calling convolutional neural networks. So it's kind of, similar to how our brain, functions. And so the computer is fed a set of images with different characteristics. Initially, it's taught what those characteristics are, and then the diagnosis is hidden, and the computer has to use what it learned to come up with the diagnosis, and then the diagnoses are uncovered, and the computer teaches itself, especially where it went wrong, in why that is, and is able to develop better algorithms and better analysis models to be able to detect those features in future analyses. And so this is interesting. This is a recent study which looked at the use of AI in diagnosis and classification of thyroid nodules based on ultrasound, and it compared the accuracy data of a junior radiologist compared to a senior radiologist compared to an AI system using those CNN networks compared to AI assisted radiologist. And it's interesting, because the AI system alone did better than a junior radiologist across all three categories, and did equally well as a senior radiologist. And what's interesting is that when a junior radiologist is assisted by AI, the scores improve significantly across all three categories. So hopefully in the future we are able to use this not to replace us as physicians, but to better assist us in terms of detecting those features that may warrant a further evaluation and management. So then I'd like to spend just the last few minutes kind of giving you a few examples and illustrating the use of both these classification systems in practice. So this is a patient with a 1.3 centimeter right thyroid lobe nodule. Per ATA, we would describe this as a solid hypoechoic nodule with regular borders and no calcifications. This, because of the hypoechogenicity of the nodule, this places it in intermediate suspicion, and FNA would be recommended if the nodule is more than or equal to 1 centimeter. Per TI-RADS, this would, the total score for this nodule would be 4, 2 points for it being solid and 2 points for it being hypoechoic, placing it in a TI-RADS 4 category, and recommending biopsy if it's more than or equal to 1.5 centimeters. So based on, if you're following ATA, you would biopsy this nodule. If you're following TI-RADS, you would just follow up this nodule with another ultrasound in 6 to 9 months or so. And so this nodule was biopsied, and it was suspicious for malignancy, so it carries a 75% malignancy rate. This is a second case. This is a patient with a 1.1 centimeter wide thyroid lobe nodule. Again, per ATA, you would describe this as a solid nodule, hypoechoic, irregular borders, especially, posteriorly. And so this places it with the microcalcifications, these echogenic foci, and this would place it as a high suspicion nodule, and you would biopsy it if it's more than or equal to 1 centimeter. Per TI-RADS, again, this is a solid nodule, giving it 2 points, hypoechoic 2 points, irregular 2 points, and microcalcifications point for a total of 7 points, placing it in a TI-RADS 5 category. That's the highest, TI-RADS category. So again, highly suspicious nodule. And for both systems, you would biopsy this nodule because it's over 1 centimeter. And indeed, this was biopsied as papillary thyroid cancer. This is a 3 centimeter spongiform thyroid nodule. Again, per ATA, we would describe it as spongiform. You can see it's mostly cystic with these little septations, giving it the appearance of a sponge. This is considered a very low suspicion nodule, and you would consider FNA. So there's no absolute indication to go for FNA, but you can consider it if the nodule is more than or equal to 2 centimeter. Per TI-RADS, it says 0 points, putting it in a benign TI-RADS 1 category, and no FNA is recommended. This was biopsied as benign. So again, you can see that at the extremes of, in case 2 and 3, at the extremes of malignancy risk, both systems, kind of fairly do well, with perhaps TI-RADS being a little bit more liberal. However, for those intermediate suspicion nodules, the size cutoff may make a little bit of a difference for some patients. So, just to kind of wrap things up, the patient comes to us with an initial risk of malignancy. So now currently being reported as 7 to 15%. So once the patient has a thyroid nodule, we assign this risk of malignancy. And based on the clinical factors and, some blood factors, that malignancy risk can increase or decrease. Furthermore, based on, other diagnostic tools, the ultrasound features, FNA if it's done, molecular analysis if it's done, again, that risk of malignancy is also altered. But I just want to stop here as well and discuss this patient risk assessment. So will identification of cancer lead to an actionable intervention? And does the patient's active illnesses take priority at present? So we often receive, referrals from our colleagues that, because the thyroid nodule is found, oftentimes, not often, but sometimes patients are perhaps, their performance status does not allow, they're not surgically fit for a surgery, even though the nodule is, highly suspicious, but what's the point of giving a patient a diagnosis of a thyroid cancer if we are not able to, to do anything about it? So again, patient psyche is very important. We also often receive referrals from oncology colleagues because a PET scan showed, for example, a focal uptake, and the ultrasound correlates with that focal uptake with a suspicious nodule. However, the patient has metastatic, something else, prostate cancer, colon cancer, breast cancer, and they're on chemo, and they're on palliative measures or whatnot. And again, we have to kind of take a step back and think about, are we helping the patient, or are we giving them a diagnosis that they have to worry about more without really being able to offer them any actionable intervention? So just kind of food for thought in terms of how you assess these patients with thyroid nodules. So again, we talked about this. So, what I want to leave you with is that thyroid nodules are common, usually benign and costly. Ultrasound neck is the first and preferred imaging modality for suspected thyroid nodules. Thyroid function should be assessed and, may need further workup if the TSH is suppressed before proceeding with FNA biopsy. And, whether we use the ATA or the TI-RADS system in terms of directing our decision-making in terms of which nodule we should biopsy, just keep in mind that, both these systems, they keep the the probability of thyroid cancer, in their decision making, and not just any thyroid cancer, but those thyroid cancers that may benefit from early clinical intervention. So that's again the bottom line here, is that we want to identify those cancers that would benefit from our intervention, whether it's surgery or follow up or whatnot. So that's the take home point of this talk is, and I'd be happy to take questions in our Q&A later on after this session. Thank you.
Thank you, Dr. Tania. The last speaker will be Professor Naif Boussaidi from Houston, Texas. She will be live with us. We are a bit 5 minutes. We'll take that from the questions, role of PET scan in thyroid cancer. Professor Naif, it's time yours.
Assalamu alaikum. Thank you so much to the organizers and colleagues for inviting me to give this talk. I am honored. I wish I could be there in person, but hopefully next time. I look forward to meeting and collaborating with each one of you. So today, the organizers have asked me to talk on the role of PET scan in thyroid cancer. And I will say that I'll give this talk with the disclaimer that I am not a nuclear physician. I'm not a radiologist. I'm not trained in these scans. I'm simply a clinician, but I do use PET scans. And so I'm going to try and talk with a clinical focus over the next few minutes. So as you saw with Dr. Jaber's talk, that thyroid cancer is the 7th most common cancer in the United States in women, and it had been rising, and the only cancer that was rising for many, many years, and finally has stabilized out in the United States. And today we're going to talk about the utility of PET scans in all 4 thyroid cancer. So papillary and follicular thyroid cancer, I'll be calling DTC throughout the talk, and then medullary and anaplastic thyroid cancer we'll cover in this talk with imaging as well. Let's talk a little bit about differentiated thyroid cancer. So as everyone here knows, that it's a 3-pronged treatment in terms of surgery, radioactive iodine, and thyroid hormone suppression. And the vast majority of patients will do really well with this treatment. About 85 to 90% of the time, patients will have no evidence of disease after these 3 treatments. So when we talk about the utility of imaging after when we have such successful treatments, it becomes a narrow and narrower field or group of patients that we're actually talking about in that 5 to 10% of patients. So let's look at the guidelines. What do they say about preoperative imaging? So, preoperative imaging is emphasized, but they talk about CT scans and ultrasounds of the neck to look at the whole thyroid. PET scan is not mentioned in preoperative imaging unless one is worried or knows that there is metastatic disease, which is a different setting. So for the vast majority of patients, that 85 to 90% of the patients that do well, to say that those patients with differentiated thyroid cancer don't have any evidence of disease, not only do we have the biomarkers, thyroglobulin and thyroglobulin antibodies that will be undetectable, we also need either ultrasound of the neck or CT neck, whichever is better at your particular place, to show that there's no evidence of disease. But the reason that is that way in the guidelines is the vast majority of disease is in the neck, right? And so you look for, that is the imaging basically that's emphasized. But for that small percentage of patients that do recur, their thyroid cancer does recur, they have an elevated thyroglobulin or thyroglobulin antibody. The guidelines talk about ultrasound or CT of the neck. And then the second place that the thyroid cancer likes to go is the chest. You can also use radioactive iodine scans. And then in a sentence, they sort of mention the CT abdomen, bone scans, MRI, and PET scan is thrown in there. So it's not as much guidance. Now, when you look at TSH suppressed thyroglobulin doubling times, the faster that thyroglobulin time is detected, then the poorer the prognosis. And so it moves fast, and we need some imaging to help us determine that. So what do we do with those patients that have elevated thyroglobulin and negative whole body scans? So those patients we're defining as radioactive iodine refractory. The ATA and NCCN guidelines, I only pick those 2 here, but you could look at other guidelines as well. They talk about a CT or MRI of the neck and chest and a PET CT scan. So why a PET CT scan is just sort of mentioned there, but not the initial screening, because the CT neck and chest is the most useful in the majority of these patients. Most of the patients that have recurrence or metastatic disease have disease in their neck and or chest. And so after neck imaging, one can do a chest CT as the second most likely place that the disease is going to be. Thin cut or spiral CT chest without contrast are good enough for parenchymal or pulmonary lesions. But if one is worried about mediastinal nodes, then they need to do a CT scan with contrast of the chest. But that majority of patients will be caught with those two imaging. So what is the utility of PET scans and what are PET scans? So a PET scan is a scan that uses positron emission to detect the absorption of radiotracer in various organs. It's considered a functional imaging, right? So it detects cellular changes rather than like a CT scan is anatomical, right? We'll tell you where it is. This is functional imaging. There are different types of PETs. Here in yellow, I've listed the PET scans that are utilized in thyroid cancer more commonly. So FDG PET, I-124 PET, and dotatate PETs. There are many other PET scans that are used in various cancers and heart disease, PSMA, for example, with prostate cancer, cardiac PETs for heart disease. But I'm just going to talk about those three types of PETs in brief. So FDG PET scan is the most common. What is that? So radioactive glucose is injected and detected by the PET scan that informs the patient and the provider about cancer, inflammation, and infection, okay? The PET CT scan now shows where this uptake of glucose is, but it's often combined with a CT scan and therefore called a PET CT. So it's the fusion of the functional imaging where the glucose goes and the anatomic imaging, which is the cross-sectional imaging of the CT. So you can get plain PETs, FDG PETs, and you can get PET CT. PET CT is much more commonly used nowadays. So what is the utility of PET CTs in thyroid disease? Well, thyroid nodules can have FDG avidity. Most thyroid nodules that have FDG avidity are still benign, as in most nodules, but the malignancy rate is increased from that baseline of 5 to 15% to 40% when there's FDG avidity, right? So higher risk of it being malignant. Now, if the thyroid has diffuse FDG uptake, that often will indicate a thyroiditis, right? So that patient might have Hashimoto's or may have other reasons for thyroiditis, but typically it's not cancer when it's diffuse. Now, FDG PETs can pick up thyroid cancers, especially more advanced disease like anaplastic, which is the most common to have FDG avidity, but one can see FDG avidity in medullary and differentiated as well. So when we talk about differentiated thyroid cancer and FDG PET CTs, not all thyroid cancers have FDG avidity, right? So I want to repeat that, and because patients ask this all the time, and they said, like lymphoma or colon cancer, why can't you use PET CT for screening? Because the vast majority of thyroid cancers are not FDG avid, so it's not a good screening tool, okay? But the more aggressive or metabolically active the differentiated thyroid cancer is, the more FDG avidity it has. Right? So it can be very helpful as a prognostic tool. Now, PET CTs are most useful if the thyroglobulin is greater than 10. Okay, so it's lower than that's not very helpful unless the histology is poorly differentiated. The other utility of PET CTs is when other imaging is negative and you're looking for metastatic disease. Okay, now, this study is is from many years ago from Memorial Sloan Kettering, but I think it's really gold and so important. It's very informative. And what they did is they took patients with thyroid cancer and looked at their radioactive iodine scans and their PET scans and whether or not they had FDG avidity or radioactive iodine uptake. And what they found was that FDG uptake on PET scans predicts mortality and predicts the lack of benefit from radioactive iodine. So if you look here, the patients who had FDG avidity, whether or not they took up iodine, they had a shorter survival than those who had no FDG avidity. And the more lesions that they had that had FDG avidity, the more that they would, the shorter their survival, right? So the PET became a powerful tool for that. Now, people always ask, is thyrogen-stimulated PET scan better than non-stimulated PET? Okay, so some people will give, just like you do recombinant human TSH-stimulated iodine scans, they do that pre-FDG PET. And so several studies showed that if you give thyrogen before the PET, you can pick up more lesions. So people thought, oh, well, maybe it's useful. So three of our centers got together and looked at patients in a protocol with thyrogen stimulation before the PET versus no thyrogen stimulation before the PET. And what we found is, yes, we can pick up more lesions with thyrogen. However, it only changed management 6% of the time, right? So we have to think about cost and time for these patients, right? And if we're picking up a tiny spot here or there, but it's not changing management or treatment, then why are we putting patients through that cost and that, painful pokes and potential adverse events, right? So we don't advocate for thyrogen stimulated PET CTs. Now, FDG PETs can also be used for response to therapy. So here's a patient who had multiple FDG avid lesions. So I'm showing you on this plain PET without a CT. And then after they got on a BRAF inhibitor, 2 weeks later, they had nice resolution of majority of those spots, right? So it's helpful to look for especially early resolutions with decreased FDG avidity, or SUV, standard uptake value. Now, what about FDG PETs in anaplastic thyroid cancer? Well, in anaplastic thyroid cancer, as you know, it's a very aggressive disease with rapid growth. And therefore, here we show Dr. Smallridge published a patient who had anaplastic thyroid cancer where they had some small disease. And within 2 months, they rapidly had growth shown on the FDG PET, suggesting that PET is very useful in anaplastic thyroid cancer. Now, PET scans can also be useful in diagnosing PET scans and staging the patients to look quickly in one swoop where the cancer may be, because anaplastic thyroid cancer, the rule is metastases, right, compared to the other thyroid cancers. And in anaplastic thyroid cancer, we can also use FDG PETs to look for early response to therapy. So this is an unpublished case of a patient who had NRAS mutated anaplastic thyroid cancer and was placed on lenvatinib and pembro and immunotherapy and had a nice response within a couple of months. What about I-124 PETs, okay, and radioactive iodine uptake? So I-124 is the radioactive iodine where it's picked up on the PET scan, and it can better evaluate patients' iodine avidity and whether they uptake iodine, whether it's likely to work. However, the problem is it's very expensive and it's not widely available. There are very few centers in the world who have that. Memorial Sloan Kettering is one of those that has this, and they do use it for radioactive iodine uptake, but also interestingly, they also use it in patients who have radioactive iodine refractory differentiated thyroid cancer, where they use, this is their trial where they use selumetinib to reuptake thyroid cancer that I showed you in the earlier talk. But I wanted to point out this was PET I-124. So here on the left is baseline radioactive, I-124, and then after the selumetinib within 1 month, they had nice uptake in the bones on the PET I-124. So there is a utility, it's just not widely available and very expensive. Now, what about gallium-68 dotatate PET scans? So the gallium-68 dotatate PET uses somatostatin analog labeled with the gallium-68 as the radio tracer, and it binds to somatostatin receptors, mainly SSTR2. Now, it is approved in several places and commonly used in neuroendocrine tumors. It's considered investigational in most countries in medullary thyroid cancer, rather than approved for use. So as a reminder, with medullary thyroid cancer, these are neuroendocrine tumors of the thyroid from the C cells, right? So different from differential anaplastic, where they're from the follicular cells. So therefore, because it's a neuroendocrine tumor, people try to evaluate this in the dotatate PET in medullary thyroid cancer. So as a reminder, surgery, total thyroidectomy with central lymph node dissection is the treatment of choice, no radioactive iodine, and we keep the TSH normal. But then we do long-term monitoring with calcitonin and CEA and imaging studies, typically of the neck, but we can do imaging of the liver and chest based on the level of calcitonin and CEA. So here I just want to show you a nice case that was published in the Journal of Nuclear Medicine by Silvera et al. That showed a 57-year-old lady who had medullary thyroid cancer, and CT scan just showed the upper mediastinal mass, and the calcitonin was in the 600s. And when they did a dotatate PET, not only do they see the mediastinal mass lighting up, they also had other pulmonary nodules and then these bone lesions. And so the dotatate PET can pick up lesions that other imaging isn't, or difficult to reach. So there have been several studies that have evaluated the dotatate PET in medullary thyroid cancer, albeit they're small numbers. So I'm going to just pick the systematic review that was done evaluating FDG PET versus dotatate PET in medullary thyroid cancer. And what they found was both FDG PET and dotatate PET are sensitive in detecting recurrent medullary thyroid cancer. And I will say, in our practice, we don't find FDG PET as helpful for medullary thyroid cancer, and we're figuring out the role of dotatate PET. But to suffice it to say, in this systematic review, they did show that both are sensitive at 72% for FDG and 88% for dotatate PET. But they, in a per patient basis, the dotatate PET may have higher uptake and higher number of lesions, and may have higher sensitivity. There was a trend towards that. It wasn't proven in that systematic review. And also there was a mention of it having better uptake in bone lesions in other studies. So we still have to figure out what the role is there. So in summary, PET scans have utility in thyroid cancer. We have to know the proper radio tracer to use in the proper cancer in the right time. And it's useful in advanced disease such as anaplastic thyroid cancer, especially for restaging or response to therapy, and then advanced differentiated or medullary thyroid cancer, especially those who are about to be on systemic therapy or as a prognostic tool, or in follow-up response to therapy. But again, we have to figure out the exact place and time that these PET scans should be used. And so I love this cartoon that Dr. Cabanillas had shown over time how things change, right? Here you have a grandmother saying, do you know what clouds are made up of? And she's looking up at the sky, and her grandson is saying, sure. He's looking at his iPad and saying clouds are made up of music files, right? So how things have changed over time, the utility of PET scans, I think, is going to evolve. And as Dr. Jabra mentioned in her last talk, we're going to use more and more artificial intelligence to help us figure out when to use what diagnostic imaging and how best to utilize those. So with that, I want to thank the entire team that helps us treat patients with thyroid cancer. And I thank you for your attention and look forward to the Q&A at the end.
Thank you, Professor Tanya. I think only I with you are alive, because Professor Tanya is not with us. No. We have questions. Thank you, Dr. Naifa, for the nice presentation. You have very elegant talk today. Well, the question is, what is the commonest cancer seen after radioiodine, active iodine? Is it solid or hematological malignancies? Okay, so Dr. Tanya with us. Thank you.
Yes, good afternoon. I was waiting for them to let me in. Thank you.
Please unmute.
Hello, Dr.
Dr. Naifa, please unmute. Yes, thank you. The question is that which cancer is more, solid or hematological malignancies after radioactive iodine?
So solid tumors are much more common than thyroid cancer. So breast, lung, and prostate and colon are all much more common than thyroid. And if you look in men, thyroid is not amongst the top. It's in women where thyroid cancer is amongst the top. And the incidence was rising up until last year, where it finally stabilized out.
So the second question, Dr. Naifa, staging or American Heart Association risk stratification for survival.
So when you look at staging for the TNM classification in cancers in general, and thyroid cancer is also a good example. The tumor size T, N is the nodes, whether it's central or lateral, and then M is whether or not there's metastases, then gets put into stage 1 and 2 for under 55 and 1 through 4, or those over 55 and over. And staging itself is at diagnosis, right? Not at recurrence. And staging predicts death. But when we talk about risk of recurrence, you still use information from the TNM, But recurrence risk is dynamic, meaning we reassess that recurrence risk each time the patient comes back. And it's very helpful to use the age of the patient, the risk factors from TNM, but there are other things that we can use, which is why it's different from staging in terms of risk of recurrence. But people love to restage patients when they come back. We're not actually restaging. It may feel like semantics. We're just reassessing the recurrence risk. Staging is a diagnosis.
So what is the best time for post-operative whole body scan after thyroid surgery? The best time for whole body scan.
So it depends on a couple of factors. So first of all, once you see the patient before the surgery and then post-op after reviewing the pathology and talking to the surgeon, I can't emphasize enough that discussion is important, then assessing the risk of recurrence to determine whether they get radioactive iodine. So once you've determined that you do want to take a look and you might want to treat with radioactive iodine, then it's worth doing that whole body scan. Okay. So once you've decided to do a whole body scan, you can either withdraw the patient or do it as a under thyrogen. Now, you can do this as soon as 2 to 4 weeks post-op, or you can do this delayed, and outcomes are not different. And we know that because they've looked at many women in pregnancy and nursing and have looked at their risk of recurrence if they delayed radioactive iodine for nursing and pregnancy and showed that outcomes are not different. So the earliest you can do it if you're doing it under withdrawal is you need at least 3 to 4 weeks off thyroid hormone. And if you're using Cytomel, it's 2 weeks of Cytomel or T3 and 2 weeks off. But if you're using thyrogen, you can do it earlier. We tend to wait for our 4 weeks post-op, but it doesn't have to be that way. And of course, if you use CT scan with contrast, there was a study out of Italy that showed, and several studies, that 1 month is probably enough, although people technically wait 2 to 3 months after contrast to do their iodine scan.
The last question for your first talk is that you believe in redifferentiation therapy. Does they have any impact on the future of the patient? Redifferentiation therapies.
I do. I think there is a role. I think we were all disappointed that it's not the cure. Right? I think we were all hoping that if we use these drugs, we resensitize the tumors to iodine, we'll use the iodine, stop the chemo, and we'll be done. And what we found out is there is a role to give the drug, sensitize the tumors to iodine, and then treat with radioactive iodine. But it's good because it gives a patient a holiday off of those toxic kinase inhibitors if they're toxic to the patient and costly. But the median is about 1 to 2 years where they can be off before they progress again. So we have to figure out the role again and the timing. Is it smaller tumors? Is it bigger tumors? Is it RAS mutated and BRAF only? Or is there a role for others? And the right drug.
Okay, thank you. Now we have a question to Dr. Tanya. The question is, it seems to be the first one simple for you. Can we do surgery without final aspiration on a nodule?
I mean, of course, we can. Ideally, we'd like to know what we're going into, because obviously, a surgery for a cancer may be different than a surgery for a benign multinodular goiter, the extent of surgery as well, the hemi versus a total thyroidectomy. So, but a lot of patients, especially in this part of the world, have misconceptions with biopsy, thinking that biopsy can cause the tumor to metastasize or spread or seed. So, education is key. A lot of the times when we go through the talk with the patient and just reassure them that, it's a very safe procedure and that we wouldn't be doing it if it wasn't, then they're a little bit more reassured. But I believe, us and the surgeons as well, they like to know what they're getting into before. And obviously, as Dr. Naifa mentioned as well, for, MTC, a prophylactic central neck dissection is warranted. So if this was, a diagnosed MTC on biopsy, the surgery would be very different than a benign or a differentiated thyroid cancer.
If one of your students asks you, can you do final aspiration without ultrasound for the nodule? What's your answer?
I wouldn't. Yeah. So I mean, ultrasound guidance is the standard of care at this point, and not just because of safety, but it's also as I mentioned, they can identify the nodule. Sometimes the largest nodule may not be the suspicious one. So a patient may have a large 4 centimeter nodule, that's the one that's palpable, that's visible, but, he may have a posterior 1 centimeter more suspicious nodule, and we typically go for the nodule that's more suspicious, not the palpable or the larger nodule. So yes, you can, but I wouldn't advise for that.
Okay. Which one, ATA or TIRAD, reduce the need for final aspiration?
Which one?
The ATA for the
So,
nodules.
Yeah, so both in our institution. So the endocrinologist. So I'm an endocrinologist. I'm not a radiologist, and we follow ATA. Our radiologists report their ultrasounds using ACR. So it's important to know both systems. And if you don't want to go to the semantics, that's why I spent a good deal of my talk focusing on the characteristics of the nodule rather than on the systems itself. So it's very important to look at the images ourselves and to be able to tell which nodule carries a higher malignant potential. And I think that kind of drives our decision much better than the report itself. But again, I believe we should, depending on what your institution does, you should probably be familiar with both systems.
Do you believe that both equally performed in thyroid nodules, or you prefer one over the others?
Again, we're talking about, yeah. I mean, I think, I think, again, I'm maybe more biased towards the American Thyroid Association, but I think both fare very, very well. The arguments for, the TIRAD system being a little bit more, liberal, or, kind of recommending less biopsies for those intermediate risk categories is also fair enough. I think the important point to both is follow-up. So, nodules that are that have some suspicious characteristics should be followed up. We shouldn't tell the patient, thank you very much, you're done, come back in 10 years. So follow-up is important. If you don't biopsy it today, you might biopsy it in 6 months. Eventually, I think, the cancers declare themselves, and fortunately for us in thyroid cancer, we for the most part, these are slow growing tumors, allowing us time to assess and reassess and, diagnose. So
there is a phobia in the media about the artificial intelligence and the problem when you replace a human by the computers. Do you believe artificial intelligence plays a strong role in thyroid nodules?
It may. I mean, the data, it's not a lot yet because it's fairly new, but it's very interesting. The paper that I referred to in my talk, like if you go through the details, like if you read it and go through the details, it's really very interesting. And the hope is that just like now we do ultrasound guided biopsies, we may be doing AI assisted radiological analysis or something like that. I don't know what we'd call it, but the hope is that we'd be smart enough to use that technology to assist us and not to replace us.
Dr. Naifa, we're having a comment on your talk about the nodules. Dr. Naifa, if you can repeat the comment, please.
Yeah,
I
think Dr. Jaber brings up an excellent point, right? I think artificial intelligence is the way of the future. I think that, sure, people have fears of being replaced. I mean, we're human after all, but at the end of the day, the humans program those computers, right? And I don't think we will ever be replaced as humans and how our brain works. We're very complicated creatures that I don't think we can be replaced, but I think we can intelligently use these AI systems in a very helpful manner in thyroid cancer management. Dr. Jaber showed a really nice study where it's helpful to add AI to the radiologist, right? The specificity changed a bit, but the sensitivity was better. And it was whether you're junior or senior, no matter how many years, Dr. Jaber and I have been in practice a long time, and I still feel that we could use artificial intelligence. So from ultrasound, which ones to test, what's the rate of malignancy, to, which ones we operate on, to mutational testing. There was a beautiful abstract in the European Thyroid Association that looked at rather than spend these expensive tests and do a whole panel, can we use artificial intelligence to help us use an algorithm how we should be testing those patients in special testing or predicting drugs? And I think that there is a utility. They will never replace humans, but I think in medicine we need to start accepting the fact that it's going to happen and adding these to our trials. So I'm happy to see these abstracts and papers come out to use AI.
Now we will go to the last talk about the PET scan, which is difficult for us. Do you think that any benefit for the PET scan? Anything for the benefit for the PET scan? If you have positive radioiodine scintigraphy, does it add anything over the radioiodine scintigraphy? I mean, it is of benefit if you have a negative radioiodine scan. But if you have positive radioiodine, does the PET add anything?
Yeah, so that's very interesting because less is known about that. So if you have a patient with radioactive iodine positive scan and has just a small bit of thyroid bed uptake, or has, maybe just a couple of lymph nodes, I don't think really that there's a utility or usefulness, right? We don't need to spend thousands of dollars on a PET scan. But if you have a patient where radioactive iodine, the patient didn't respond as much, right, as you expect, they had beautiful uptake, but they're not responding as much, or they're progressing where they took up iodine, right? So by definition, they would be radioactive iodine. You can have heterogeneous uptake of iodine. Some tumors take up, some don't, and it doesn't work as well, which is where people who use I-124 find that more helpful than I-123 or I-131. But in the Memorial Sloan Kettering study from, I believe, 2006, they did show that you can have FDG avidity and radioactive iodine avidity and still have lower mortality. So if you have FDG uptake, if a patient's, I think the role would be if you had somebody who had radioactive iodine uptake but is not responding as well, then a PET scan may have a utility. But again, I would think about, I'm ordering this test only if it's going to change my management. Right? I'm not just doing it as FYI information because I just put a patient through a test I didn't need. So, in our earlier sessions, Dr. Ramsey had mentioned being a minimalist, and I think it's important that we keep the patient at the center of decisions and not over-order tests. So it's a low population of RAI positive that would need a PET scan, a handful.
Okay, and what about the prognosis? Does it add anything for the prognosis of thyroid cancer, the PET scan?
It does. FDG avid PETs are very helpful because if they're FDG avid, the tumors are more aggressive, more metabolically active. So the patient in general will have a shorter survival and do poorer. So it does have prognostic value, but I don't think that if we took the whole denominator of thyroid cancer patients that we should use that as prognosis. I think if there's there are so many patients that are radioactive iodine refractory or borderline, and some of those patients die early of their disease, and some of them GSH suppression is enough. I think the PET scan can help differentiate some of those. So it is. You mentioned
that medullary thyroid cancer, the benefit is questionable. It's not very, very impressive.
So I don't find FDG PETs very helpful in medullary, but I do have to quote the literature in that they do show that FDG PETs can be sensitive, anywhere from 45 to 75% of the time. I see that people order it because they don't want to order CT scans of the liver and the chest, right? They just want to do one scan. I'm not as convinced in my clinical practice, but the papers do show that it can be helpful. It's not as helpful for bone lesions. It can be helpful for soft tissue lesions. FDG PET.
Thank you. Dr. Tanya, if you have any comment or question to Dr. Naifa, because
I'm just very glad to be on the same panel as her. So.
Dr. Naifa, if you have a question to Dr. Tanya or comment on her talk.
Yeah, no, so I thought your talk was excellent, Dr. Jaber. Dr. Tanya, it was very, very informative. And I think that this, like you eloquently had said that, people focus on TIRADS versus ATA and which one do we use. And it's really, it's a gestalt, right? Like use it as a guide, whichever one you want to use it as a guide, look at your own pictures. If you're an institution, the radiologists do it, you hope that they also use it as a guide. So in our institution, for example, we just had to make a template and make a choice, right? Of which algorithm to use. But we ended up, let's say using the TIRADS in our reporting, but everybody knows the radiologists are looking at the pictures and the gestalt, but they just had to put an algorithm in the report. But it's not because TIRADS is the be all and end all. It's not the only decision. We're using everything. So I think we just have to be careful, but I thought you eloquently stated that and it was very true. So thank you.
Dr. Tanya, as an endocrinologist, you prefer TIRADS or ATA?
You want to find an answer, don't
nobody
you?
accept that.
Again, in my, I trained under the ATA guidelines, and I use it more frequently in my clinic. So I usually resort to the ATA, but I think they're both equally.
And what about Dr. Naife, Professor Naife?
I use I don't do my own ultrasound. So our radiologists at our institution do them. And so, we use a combination, but when I look at the pictures, I also was trained under ATA, but I think it's a bias of thyroidologists.
What the trend in the state among endocrinologists?
I would say, I don't know. I haven't looked at a formal study. Actually, Dr. Jabra might have looked at the literature, but a lot of, the colleagues use ATA more, but, it depends if they're doing it themselves or their radiologists are doing it, but I would say ATA probably is used more, but I don't have the study to back that up.
I think, yeah, I completely agree. Like it seems that endocrinologists sway more towards ATA and radiologists maybe towards ACR, but.
We conclude at the end of this session. A great thanks for Professor Naife and Professor Tanya. We will again to talk, and thank you very much. We hope to see you in the next year. Thank you very much.
Thank you.
Thank you.
Have a good evening. Bye-bye.
Bye-bye. Bye-bye.